Good afternoon, everyone. A warm welcome to all our participants joining us today for this insightful webinar, Sweet Danger, How Diabetes Hurts the Heart. I'm Ajay Nair, and I'll be your host for today's session, proudly presented by ONUS Robotic Hospitals, Hyderabad, a leader in advanced cardiac and robotic healthcare. Today's session focuses on a topic that affects millions: how diabetes silently damages the heart and why timely awareness and prevention are crucial. To help us understand this vital connection, we have with us Dr. Vinod Vadthya, an esteemed interventional cardiologist at ONUS Robotic Hospitals, known for his expertise in complex cardiac interventions and preventive healthcare. Dr. Vinod will share how diabetes impacts heart health, the warning signs to watch for, and the proactive steps we can take to protect ourselves and our loved ones. We encourage you to stay tuned till the end. There will be a short Q&A session where Dr. Vinod will answer some of your questions. So without further ado, let's begin this enlightening session. Over to you, Dr. Vinod Vadthya.
Thank you, Ajay sir, for warm welcome note. So today burning topic in Indians, heart attack and heart diseases. So today I'm going to discuss about the diabetes, how it affects our heart. So the topic name, Sweet Danger, how it affects our heart. So yeah, what are the objectives I'm going to take here? Understand the pathophysiological link between diabetes and cardiovascular disease, and review and major clinical trial evidences, and discuss the advances in cardiology regarding these therapies and technology, and summarize and recommendations, guidelines. So epidemiological burden. So diabetes affects over the 500 million people globally. So among these, CVD accounts around 70% of deaths among diabetes. Diabetes increases myocardial infarction and stroke risk 2 to 4 times. Rising prevalence in South Asia due to lifestyle and genetics. So Indian perspective, over 101 million adults with diabetes and 136 million among them having pre-diabetes. So number is projected to cross 150 million by 2046 according to IDF Atlas. So urban prevalence is 16 to 18%, rural 6 to 8%. So diabetes onset occurs 10 years earlier in Indians when compared to Western population. So what about the implications shows that longer exposed to hyperglycemia, which leads to higher lifetime risk for heart diseases. So heart disease is a leading killer in Indian diabetics. 65 to 70% of deaths in Indian diabetics are due to cardiovascular deaths. So high rates of premature coronary artery disease onset before the age of 50 years. Coming to South Asians have smaller coronary arteries and more visceral fat and higher insulin resistance. Higher burden of silent ischemia due to autonomic neuropathy. Indians develop CAD a decade earlier when compared to even though lower BMI patients. So why Indians are at higher risk for cardiovascular diseases? First comes under genetic predisposition, high insulin resistance, even in lean individuals, those who are in low BMI levels. We can think of that high BMI, obese patients will prone for heart diseases. But now when patients having genetic predisposition, even lean individuals will have heart diseases. So urban lifestyle, sedentary lifestyles, food habits, high carbohydrate diets, low physical activities, lack of proper sleep, and due to stress, and obesity pattern, central abdominal obesity, which leads to more metabolic risk and leads to metabolic syndrome and diabetes and heart diseases. So here low LDL, low HDL, high triglycerides are more common, which leads to atherogenic dyslipidemia. So poor awareness and late diagnosis of both of diabetes and cardiovascular disease. What are the clinical and public challenges, health challenges among Indians? So poor glycemic control, average HbA1c 8.5%, and limited access to cardiac diagnostics in rural areas. Low use of cardioprotective agents like newer agents, SGL2 inhibitors, GLP-1 receptor agonists, and due to more cost. So cultural diet barriers like Most of the patients are taking high carbohydrate, sweets, lack of multidisciplinary diabetes and cardiological clinics. Here we can say that more of the patients, those they detected for diagnosed for diabetes, and they have put on some medicines earlier. They will try for their lifestyle modification initial stages, but even though for few days they will do some exercises and food habits, after that they leave, and after few days, after few months, they will approach the clinics or hospitals with high danger notes, like they develop meanwhile higher sugar levels, diabetic ketoacidosis. Most of the patients present with heart failure presentations, and heart attacks also we have found those patients having high sugars recently diagnosed. So we need to go for better multidisciplinary diabetes and cardiology clinics and awareness programs. So what is the pathophysiology behind, and what are the metabolic connection? Here, insulin resistance, which leads to hyperglycemia and endothelial dysfunction, advanced glycation and end products, vascular stiffness will occur, lipotoxicity and oxidative stress will lead to myocardial damage, chronic inflammation leads to atherosclerosis progression. Here in flow chart, I can show here diabetes, hyperglycemia, hyperinsulinemia, insulin resistance, long-term excess sugar intake will lead to glucose toxicity, which leads to fibrosis and systolic diastolic dysfunction both. And here AG is increased and RAG is ROS, reactive oxygen species will increase, and inflammation, oxidative stress, all other vascular smooth muscle dysfunction, vascular remodeling occurs, all this leads to oxidative stress, dyslipidemia, inflammation, which leads to myocardial fibrosis and cardiomyocytes death, diabetic cardiomyopathy, diabetic here cardiovascular disease. Ultimately, whatever the diabetes and cholesterol deposition leads to atherosclerosis in arteries here. So diabetic hyper, same thing we are going to discuss here. FFA oxidation, free fatty acid oxidation, decreased glucose oxidation, lipotoxicity will increase, altered metabolism, and here AG is accumulation, ECM remodeling, and myocyte apoptosis fibrosis leads to LV concentric hypertrophy and diastolic dysfunction. Calcium impaired homeostasis and increased probiotic and inflammatory cytokines will increase, leads to oxidative stress in inflammation. So ultimately leads to heart failure. Here, same thing depicted in one picture, diabetic heart disease, same thing. And here I have added some autonomic dysfunction, neurohumoral mechanisms, and myocardial cell death pathways, altered substroke utilization, mitochondrial dysfunction, oxidative stress, inflammation, glycation, and AGEs. So multifactorial contributors to diabetic cardiomyopathy. So effects of diabetes on heart, how it affects. First, coronary artery disease, which leads to plaque burden. So over the period, it develops into heart attacks. Diabetic cardiomyopathy, fibrosis, impaired relaxation leads to diastolic dysfunction in patients with heart failure. Heart failure patients, yeah, microvascular and metabolic injuries will occur. Arrhythmias will lead to sudden heart failures, which is due to secondary autonomic dysfunction. Silent ischemia, neuropathy, master symptoms. Here we can see most of the patients present with heart failure symptoms. In diabetes, we can think of classical angina symptoms won't present with diabetes patients. Here, autonomic dysfunctions leads to autonomic neuropathy, which masks the symptoms of like classical chest pain, anginal symptom, neck pain, or jaw pain, whatever the symptoms we know, anginal symptoms, they won't be present in diabetic patient because of masking of neuropathy, masking of autonomic nervous system, which leads to silent ischemia. Here, this we can see this diagram of heart depicted with coronary. These are the veins, the red colors are arteries. Arteries, right? RCA, LAD, L6 are there. Here, artery. This is a lumen. This is a healthy artery with having these are the blood cells. RBCs are there inside. So there is no any deposition of fat or any cholesterol here. So the clean, healthy heart artery we can see here. After that, over the period when we are having lifestyle changes or unhealthy food habits, here cholesterol deposition. So initial fat deposits here, which leads to over the period plaque burden increases, which obstructs the blood flow. And when stress increases, it completes whatever the 90% blockage will become near complete blockage and leads to coronary artery disease and we can say that heart attacks. Same thing, type of the lesion here. Here complete, here stenotic, few fibrotic thick cap, less compensatory enlargement here. And here complete occlusion will be there, many lipid rich thin cap, compensatory enlargement. Infarctions is a complete accumulation. So infarction local therapies and revascularization like PTCS, stent and CABG we can opt in this patient. Those who are having ischemic early stages, we can go for systemic therapies like lifestyle modification, drug therapy initial stages. So here structural changes in diabetics with cardiomyopathy, hyperglycemia, hyperinsulinemia, which leads to insulin resistance. Here this is a normal heart. Here this is the interseptum. This is the left ventricle, right ventricle. Here you can see this is the interseptum, which is a left atrial dilatation occurs here, and thickness fibrosis which deposits in the septum. So which leads to cavity size of the left ventricle, which leads to diastolic dysfunction. Relaxation will be impaired in patients with diastolic dysfunction with diabetic cardiomyopathy. So what are the lifestyle and risk factor management? So these are the effects caused by diabetes on cardiovascular systems. So first, we can go for a systemic approach with lifestyle and risk factor management. Prevention is better than cure. So we can go for lifestyle first. So what are the non-pharmacological cornerstones? Diet, we can go low saturated fat, high fiber intake, low glycemic index foods. We can calculate our calories while taking food, and exercise more than 150 minutes per week, which includes aerobic and resistance training. So you can go for 5 days in a week exercise, you can opt for that. Our weight reduction target BMI should be less than 23 kg per meter square for Indians, and smoking cessation, alcohol moderation. So you can say alcohol with the alcohol and smoking. So what are the targets according to ADA 2025? So HbA1c should be less than 7% individualized, and BP should be less than 130/80, and LDL cholesterol, which is bad cholesterol, less than 55. Very high risk patients having coronary artery disease, so near target less than 55. So triglycerides less than 150 we should keep. What are the pharmacological therapy nowadays available for heart diseases? So first, though these are all comes under coronary artery disease here. Antiplatelet therapy, which include aspirin for secondary prevention, clopidogrel, ticagrelor, prasugrel in the dual antiplatelet therapy. So those patients having MI and underwent for PTCA, we can call it post PCA, and continue DAPT typically for 6 to 12 months after stent placements. So this is antiplatelet therapy. Then lipid lowering agents. High intensity statins, initial days around atorvastatin 40 to 80 milligram or rosuvastatin 20 to 40 milligrams. We need to take those patients with high risk, and those patients underwent for PTCA or stenting. So add another group of drugs, estomib or PCSK9 inhibitor if LDL, even though not controlled with high dose of statins. So statins reduce the CV mortality even when baseline LDL is modest. So after that, glucose lowering agents, not only antiplatelets and statin lowering agents, glucose lowering agents, which includes CV cardiovascular benefits. So these are the newer agents, SGLT2 inhibitors, empagliflozin, dapagliflozin, which decreases recurrent heart failure, hospitalizations, and cardiovascular death, recommended in all patients with CAD, with diabetic, without heart failure. And GLP-1 receptor agonists like liraglutide and semaglutide, these are nowadays decreases MACs and MIS stroke, CV does improve endothelial function and weight. So metformin is still first line of unless any contraindications when patients having less than GFR is less than 30. What are the drugs patient having coronary artery disease? So we can go for beta blockers, post MI, LV dysfunction patients to control the arrhythmias, AC inhibitors to reduce the mortality and heart failure risk. Is aspirin, statins, and ACE based triple combination therapy. Ranolazine evaporated in selected cases for symptomatic anginal pain control. So this is a main revascularization. Patient had heart problem in the sense of heart attacks. So first we can go opt for PCI, drug eluting stents, percutaneous coronary interventions. Nowadays We are going for drug-eluting stents, so which includes in focal areas where the focal diseases are present. So preferred in focal when stentable places like patients having heart disease presented with MI, where is minor, not minor, it's a complete occlusion of the artery, which is life threatening. We need to go for stenting immediately. No need to wait for anything. So PCA is the most prominent and most nowadays we are practicing. Then second is CABG, coronary artery bypass. So this is a mainstay. Most of the patients asking for whether we go for CABG or PCA, we can say PTCA, stenting or CABG. There is a big debate between these two. So CABG we can opt for when patients are not able to go for stents or vessels are not stentable. So multiple blockages and vessel is not good for any grafting. So those patients we can go for PCIs and CABG multiple blockages in one sitting we can go. But pros and cons are both are almost near equal. There are a lot of debates are going on. So early invasive strategy improves the outcomes in diabetes with acute coronary syndrome. Superior long-term survival in multi-vessel disease, which shows the freedom trial says the CABG is superior to PCA for mortality and MI in reduction in diabetics. So hybrid revascularization may be used in select complex cases. So here, what are the drugs in heart failure? So commonly used current pharmacological therapies to lower the hyperglycemia, including diabetes, and which which decreases the heart failure symptoms here. Biguanides, sulfonylureas, tergipides, and GLP-1 agonists, DP4 inhibitors, SGL2 inhibitors, and insulins, which ultimately act on skeletal muscle, adipose, and kidneys, and pancreas and liver. So diabetes and multidisciplinary approach. So these are the oxidative inflammation which hampered by these drugs. So what are the clinical trials ongoing? IMPA-REG outcome shows that empagliflozin, which decreases CV death by 38%. Leader trial shows that liraglutide decreases MACE by 13%. Declare TIMI 58 shows that dapagliflozin less than heart failure decreases heart failure hospitalization. Select trial shows that semaglutide decreases CV mortality by 20% in obesity. So technological innovations are there, continuous glucose monitoring nowadays, AI integration is there, smart insulin pens and pumps for precision and dosing, machine learning in early detection of the cardiovascular risk, remote monitoring and telecardiology nowadays going to, and what are the guideline updated? So start SGLT, GLP-1, early stages in diabetes with CVD or CKD, lower LDLs, target should be less than 55 for very high risk patients. Encourage multidisciplinary cardiodiabetic clinics, individual HbA1c less than 6.5 to 7.5 and based on comorbids. So prevention and lifestyle, early screening for CVD in diabetics more than 40 years, control BP less than 130/80 and lipids aggressively, diet like plant-based, low sugar, low saturated fatty acids, physical activity more than 150. We discussed earlier, smoking and alcohol should be stopped and stress should be properly managed and proper sleep should be taken. So future direction, same thing, precision medicine, genetic and molecular profiling will be going to, so triple acting incretin therapies are available, integration of wearable sensors and AI diagnostics and population level prevention programs are going to happen in future. So summary says that diabetic and heart disease share common mechanisms. Modern therapies to be go beyond glycemic control to protect the cardiovascular system. AI and technology are reshaping diagnosis and care. So early integrated management improves the outcomes. So, so leading the way in advanced cardiac and diabetic care at ONUS Robotic Hospitals, Champapet. Thank you.
Thank you, Dr. Vinod. Thank you so much for that insightful and eye-opening presentation. We'll now move on to the Q&A session where Dr. Vinod will be answering some of your questions about how diabetes affects heart health and ways to prevent complications. If you haven't already, please type your questions in the chat box or Q&A panel. We'll try to take as many as we can in the next few minutes. Okay, we have some questions here, Dr. Vinod. These are quite very simple questions for you. Many people know diabetes affects blood sugar. So how exactly does it harm the heart? I mean, if you can put it in layman terms.
Yeah. Thing is that not going to scientific or like in our cardiology or clinical basis, but thing is that heart and diabetes is a mainly sugar deposition occurs which leads to whatever we have discussed. Mechanisms are there, mechanisms which leads to hyperinsulinemia or sugars levels are high. Sugars ultimately damages the heart muscle and muscle thickness will increase. Heart muscle increases. Simple, I can say one thing. When patient, when we are going for regular exercises, when we are building our body and when our biceps will increase, like that, when patients having long-term diabetes, so which leads to sugar deposit, hyperinsulinemia or whatever we can say, hyperglucose, which leads to insulin resistance and what ultimately leads to heart muscle thickness. Heart muscle thickness leads to cavity size. Size will be compromised. Heart size will be compromised. Lumen size will be compromised. So here, normally when blood comes from the other parts of the body to reach our heart, from there is a left atrium, left ventricle, it will take the blood and pumps out. So heart should be taken that blood into the cavity. Then proper space should be there to take the blood. When cavity compromise, there will be disturbance, like we can't pump properly. There won't be time for relaxation. So heart itself says that contraction and relaxation, systole and diastole we can consider. So in diastolic dysfunction will occur in diabetes patients leads to heart failure. There won't be proper blood accumulation in the heart and it won't pump. This is one mechanism. Other mechanisms are oxidative stress and free radicals will be released. And over the period, this is about cardiac muscle. Another part, there is a coronary artery lumen. Heart itself, it requires blood, oxygen for living purpose. Then this, they have three coronary arteries, right one and left two, three coronary arteries embedded on the heart. These coronary arteries are, over the period, blockages will occur because of sugars, because of cholesterol depositions in the luminal artery lumens, will lead to small plaques. Over the period, it will occlude our coronary artery. Lumen will be stopped. Lumen will be compromised, leads to heart attacks. This is another one. And some patients will have heart failure symptoms. Some patients will have autonomic nervous system disturbance. Some patients arrhythmia. Some patients will have heartbeat will be higher side. Like we can say, few patients telling that I have some unaware. I'm unable to. We can say I'm aware of my heartbeat. Palpitations we can call it as. So palpitations, like whether the palpitations is normal anxiety related palpitations, whether because of skipping our heartbeat, because of irregular heartbeats are there, because of diabetes, which leads to autonomic and arrhythmias will occur. So this leads to heart failure over the period. So these are the mechanisms behind diabetes and heart diseases.
Thank you, doctor. Thank you for that very informative answer. And that also answers the question why heart attacks and strokes are more common in diabetic patients, right? So my next question is, are there specific tests diabetic patients should take regularly to monitor their heart condition?
Yeah. So there are basic tests like every diabetic patients, first they should control their sugars, like fasting blood sugar, post lunch blood sugar, 3 months average glucose levels we should monitor with HbA1c levels. These are basics towards diabetes. What about heart related? Heart related, we can go for regularly ECGs, 2D echo, whether diastolic dysfunction is there or not. And then if patients able to do, we can go for stress tests like ECG stress test, TMT we can call it as, and some stress echo will be there. We can go for that. Dobutamine stress echo is there, and some patients we can tell them to go for CT coronary angiograms, whether any blockage is there or not in our coronary arteries, whether any calcium deposition are there, what is the morphology of our arteries. So we can go. These are the preliminary tests till we can go for advanced coronary angiogram. This is the main leading coronary angiogram is the main test to detect our blockages. So before that, these are the disciplinary one systematic approach will be there.
Thank you, Doctor. You have answered most of the questions, most of the queries, or most of the FAQs that people might have for heart diseases related to diabetes. And also, it's very important to get early diagnosis to prevent diabetes-related heart damage, right? Thank you, Doctor. And as we come to the end of today's session, we'd like to express our heartfelt thanks to Dr. Vinod Vadthya for sharing his expertise and shedding light on this vital topic, that is sweet danger, how diabetes hurts the heart. A big thank you to you as well, to all our participants for joining us today and making this session interactive and meaningful. Before you leave, we'd like you to take a moment to fill out the post-webinar survey that will pop up on your screen shortly after this webinar. Alternatively, it'll be also on your email. You can fill it from there as well. Your feedback is very important to us. It helps us make our future sessions even more engaging and informative. So stay connected with ONUS Robotic Hospitals Hyderabad for more expert-led health webinars and updates. Until next time, take care, stay healthy, stay happy, and remember, a sweet life is best enjoyed with a healthy heart. So thank you for now and see you later. Thank you.
Thank you.